Good afternoon, everyone. My name is Aisha Dixon, and I'm the director of the UCLA Emeriti Retirees Relations Center. And we're so glad that you can join us this afternoon for this special program. I worked on this program with our colleagues at the UCLA Retirees Association and the UCLA Emeriti Association. And a special thank you to Emeritus Dan Mitchell for coordinating this program with the LA County Public Health Director, Barbara Ferrer. You currently do not have the opportunity to unmute yourself, but once we get towards the end, we will allow people to raise their hand and ask more questions. We did have a list of people who submitted questions in advance, so we'll be addressing those. So again, feel free to type your question in the chat, and I'll go ahead and turn it over to Michael Heafy.
Welcome, everybody. Greetings to you, Dr. Ferrer. Thank you for joining us today. I'm the program chair, and I share somewhat of the responsibility or blame with Steve Cederbaum for our activities here. And I welcome you all, and let's hear it from Steve. Thank you.
My welcome as well. As you all know, that we're living through a very profound social event and experiment. I'd sort of likened it to the merry-go-round either on Santa Monica Pier or Griffith Park. There's lots of ups and downs, and it goes around and around and around. And at the apex of this whole mess in Los Angeles County is Dr. Barbara Ferrer, who must be leading a very interesting life in the last 18 months. And we probably will hear something about that in her talk today. We're very fortunate that she, as the director of the LA County Department of Health, can share this experience with us, or at least part of the experience. Dr. Ferrer is a nationally known public health leader with over 30 years of experience in many very different places. When I looked her up online, I discovered that she has been a philanthropical strategist, public health director, educational leader, a researcher, word I don't like, investigator is more to my taste, and a community advocate. She has a proven track record of working collaboratively to include population outcomes through efforts to build health and educational equity. And I have to say that she's really a cool lady, that no matter what crap is going on, she always seems in the public interviews to be calm, cool, and collected. And maybe we'll hear more about that. But in any event, Dr. Ferrer got her Ph.D. in social welfare at Brandeis University. She received a Master's of Art in Public Health from Boston University, a Master of Arts in Education from the University of Massachusetts in Boston, and a Bachelor of Arts in Community Studies from University of California, Santa Cruz. And I just think that we're very lucky to have Dr. Ferrer here today, and welcome, Dr. Ferrer, and thank you in anticipation for joining us.
Oh, thank you so much, Steve, Michael, and Aisha for the invitation, and for all of you for joining us and getting together today, even if we are virtual. I do want to thank the Emeriti Association for this invitation. I'm honored to talk to so many people with very impressive backgrounds in public health, epidemiology, physics, and many other fields, obviously in health and science. And hopefully, the next time we have an opportunity to be together, we're able to do that in person. I do want to note that it's very special to do a presentation during this month of November, which is Native American Heritage Month. And I want to join you in recognizing UCLA's presence on the traditional, ancestral, and unceded territories of the Gabrielino and Tongva peoples. I do hope that I'll be able to share with you for about 20-25 minutes a look at the past 20 months of the COVID-19 pandemic. I want to really focus on the disproportionate impacts it's had on communities of color, particularly the Black and Latinx communities, and then close by just noting some of the root causes of the inequities that we're seeing. I'm grateful to obviously have an opportunity to discuss these challenges with you. I'm also very eager to hear from you at the end of my presentation. And so we could get started. Obviously, the first slide. And we could actually now go to the second slide pretty quickly. I want to go through this quickly so I can let folks have plenty of opportunity to talk.
Let me make sure so that you can see the first slide.
Yeah.
Let me make sure I can get to the next one. Is that the second one?
Yes.
Perfect.
Just so you know, this is really how I've organized the presentation part of this. I'll talk a little bit about what we saw over the 20 months, looking at it by race and ethnicity, also by geography. I want to talk a little bit about root causes of disproportionality, closing gaps, efforts we've made, and then needed policy and practice changes. Sort of what are the lessons we've learned about what we need to do next? And then leave plenty of time, I hope, for questions and answers. We can go to the next slide. So this is an age-adjusted trend line of cases per 100,000 people by race and ethnicity through October 30th of 2021, starting way back last year in March. And a couple of things I want to point out. One is the lines are color-coded. The yellow line that you see that sort of dominates during our surges is the case rate for Latinx residents. The green line, which you see is really almost consistently also up at the top here, represents the experiences of Black and African-American residents. The case rate for whites is in sort of the orange line. And then for Asians, that case rate is captured in the blue line. What I think is important for us to realize is that we've always had gaps, but the gaps get huge when we're in the middle of our surges. So we've had really 3 cycles of noticeable surges. I mean, obviously at the beginning, it was all felt like a surge, but really we had a summer 2020 surge. We had a winter horrible surge, as you can see here. 2020 into 2021. And then we had our summer surge that started in July of 2021. And in each of these instances, gaps that had been closed, although never entirely, just widened exponentially. So the case rates for Latinx people during the surge were in many cases over 10 times the rate of cases that we were seeing, particularly among Asian populations, which have historically had some of the lowest case rates. Everybody goes up, everybody comes down, but the disproportionality really hits us hard during the surges. The other interesting thing to note is the Latinx community has been the hardest hit, and I'll show you more data on that. But in this latest surge, you'll see that the experiences of Black residents was worse than it was for everybody else. And this, in fact, as you all know, by the time we got to the summer surge, we had a lot of people vaccinated. So A, the numbers are lower, and B, we start flipping who's most impacted because in correlation actually to what we know about vaccination status. So just important to keep that in mind. We can go on to the next slide, which really similarly, is there a way to advance to the next slide? Yeah, perfect. So this is similar. This is now looking, same color coding on the trend lines, looking at hospitalizations, same pattern, you know, huge gaps during the surges. They narrow, particularly the more recent differences between what happened after the winter surge and until we got to the summer surge. Latinx communities, again, hardest hit with cases, and there's a direct correlation between cases and hospitalizations. And then African Americans in this last surge having many more hospitalizations when compared to everybody else. And also important to note here, as we're looking at the hospitalization rates in particular, that the rate of hospitalizations compared to cases also has shifted over the course of the pandemic. So we won't have time to actually take a good look at that. But again, because of vaccinations, we now have about 5 to 6% of people who end up testing positive in the hospital. During the winter surge, that was somewhere between 15 and 25%. Again, nobody was vaccinated at the time. Next slide is just, again, similar trend line, now looking at deaths. I think it's important to note here that how much we've been able to reduce deaths even in our last surge, again, probably closely correlated to the fact that we had lots of people vaccinated. You can take the next slide. So if you look at it by race, you see a lot of disproportionality. You also see a lot of disproportionality if you look at it by geography. And this can also be understood as sort of race and geography are intimately linked in LA County. Many of our communities that you see here, they're kind of marked out in what I say is these blue lines. Those are what we call our hardest hit communities. They are historically communities that have been less resourced with health affirming opportunities. And you could just look quickly and you'll see that the highest case rates are in those communities, have the highest rates of poverty, but also the highest rates of environmental degradation, disinvestment in infrastructure. So that Healthy People's Index really represents 30 different metrics that allow us to look at communities in terms of their ability to support optimal health and well-being. And those communities highlighted here in blue are the communities with the least resources to do that, and the communities with the highest case rates, those are the darker shades, and the communities with the highest proportion of people of color. So we have a lot of residential segregation in LA County, and you can see it on some of the maps. This is cases. If we flip to the next slide, you'll see something very similar on hospitalizations, looks almost identical. And then if we go to the last slide, the next slide, you'll be able to see how we've captured this for deaths and the relationship between who died from COVID and levels of poverty in communities. So this is stark. Communities that have very little poverty have much lower death rates than communities with high levels of poverty. And at every incremental increase in the proportion of people living in communities with less resources, you see an increase in the death rates. But this is almost 4 times the death rate in poor communities as that experienced in wealthier communities. Next slide. And a similar, I want to also show similar gradient as well. Unfortunately, if we look at death rates, and these are cumulative age-adjusted death rates, but if we look at those by race and ethnicity, somewhere between 3 and 4 times greater death rates among brown and Black people than amongst Asian and white people in LA County. Next slide. And I show these numbers because I don't think we can talk about COVID or frankly any other health issue in LA County without focusing in on the disproportionality that plays out over and over and over. But this time we saw it right in front of our own eyes in a very short time frame. If we were to look at other health outcomes, diabetes, cancer, infant mortality, maternal mortality, heart disease, we would see similar differences by race and ethnicity and also by level of poverty. But many times those are playing out over a much longer time frame. What's horrifying here is how quickly this played out over a matter of months, not just in LA County, but across the country. And I want to talk a little bit about sort of vaccinations, because I've alluded to the fact that once we got to the summer surge, rates of vaccination started having an impact. And again, you can see here that there's pretty significant differences still, now at the end of October, this went all the way out till in between who's vaccinated. And Asian people have the highest vaccination rates, followed closely by white residents. And obviously with lags, white residents and American Indian, Alaska Natives, and with big lags for Latinx residents here in orange and African Americans, Black residents here in green. And I put this up, we don't have a lot of time, but I put this up because I want to note these differences, and then I want to talk about some of the factors that may help explain these differences. And certainly now these differences are contributing to some of the gaps we continue to see in health outcomes associated with COVID. Next slide. Similarly, vaccine coverage differs by race and ethnicity and differs again by zip code. And, again, these areas highlighted with the blue lines are, what we call our health, our HPI. This is our index that we use to denote under-resourced communities. And, it's so easy to see that these under-resourced communities, also high percentage of Black and brown residents, but also a high percentage of poverty, again, have the lower rates of vaccination coverage. So doing much better on vaccination coverage, and I'll show you that slide later, but where there are lower rates are, again, in some of our communities that unfortunately you saw earlier. These were the hardest hit communities even before we had vaccines. And now we have them hardest hit communities with lower vaccination rates going into what could be a difficult winter. Next slide. The reason I talk a lot about vaccinations and worry a lot about the gaps is because, as you can see on this slide, being unvaccinated creates huge risks for those who are unvaccinated and unfortunately for those around them. So in this complicated slide, I apologize, it's a little busy. In the green shades, we're really looking at cases, and in the yellow shades, we're looking at hospitalizations, and we're looking at it by race and ethnicity. It's clear immediately that both for cases and hospitalizations, you have a much higher chance of getting infected and ending up in the hospital if you're unvaccinated. And again, for cases, the distribution isn't all that different by race and ethnicity any longer. This is recent data, okay? This is not cumulative, this is recent data. And you can see, they're not the same, but, pretty similar. But for hospitalizations, the rates are still slightly different. And with white and Asian residents, even those unvaccinated, having lower rates of hospitalizations. Now, this is probably associated as well with underlying health conditions where Black and brown residents in LA County have much higher rates of serious chronic health issues than white and Asian residents. But again, important for us to keep this in mind and important to understand why we're so focused on vaccinations. And while the gradient isn't huge here for cases, it is worth noting that, it is important to see the differences that we have in who's getting infected and then who's ending up in the hospital. But this is a sign of a little bit of progress in closing some of our gaps. Next slide. So I want to just pause for a second. I've shared a fair amount of data, just trying to give you a snapshot, sort of where are we? We have these gaps. We always worry about these gaps opening back up in a surge. If we have a winter surge, I think this picture that you just saw that showed some similarities amongst different racial and ethnic groups disappears again, because whenever we're sort of not in a surge, we're able to narrow the gaps. As soon as we get to a surge, the gaps grow. But I want to also note that it would be impossible to have a conversation about what's contributing to these gaps without acknowledging the social determinants of health that really so strongly influence overall health outcomes, but also play a role in what we're seeing in COVID. And you can see, we talk about social determinants as falling into, 5 different categories, and different people categorize them differently, but I think they all make sense to everyone. Economic stability has an influence on your health status. Your education has an influence. Health and healthcare, not just your access to healthcare, but also, how you're treated and what your experiences are when you get your healthcare. And then your neighborhood and your built environment. It's one thing to tell people to eat healthy and exercise, but if their neighborhood doesn't offer affordable, healthy food options, full service supermarkets, farmers markets, that's going to be difficult. If there aren't safe places for people to be outdoors, that's going to make a difference. If there's a lot of density of, sort of alcohol, tobacco, and cannabis establishments crowding out other more healthful establishments, that makes a difference. And obviously environmental exposures, which everybody in LA County is acutely aware of. Sort of where is the air quality the worst? Who's got exposures to oil wells and active drilling? Where do we have our most polluted neighborhoods? Where there are problems with lead in the water? All again affect people's ability to be healthy. And we also like to talk about the social and community context. We think social cohesion plays a role. And again, we're heavily influenced by our ability to be able to participate fully in civic life, who's incarcerated, who's not incarcerated. So we think all of this plays a role in everyone's health outcomes. We put racism and discrimination on top of all of these different determinants sectors, because racism and discrimination affect every single thing that we talk about in every single one of these dimensions. It's impossible to be in the United States and not understand the detrimental impact of racism and discrimination on your ability to have stable income, on your ability to get a high quality education, on your access and your treatment in the healthcare system, on what neighborhood you live in and what resources are available in that neighborhood that promote your health, and what is happening to the social fabric in which you're participating. So I put it on the top. Obviously, we could talk about this for a really long time, but we're not going to have time to do that today. But it is to acknowledge that as we think back on all of the inequities that I just showed you, if we don't focus on the fact that what influences people's health and well-being are all of these factors, then the solutions to the disproportionality that we're witnessing now and that we've witnessed historically for all of our health outcomes becomes really difficult to address. And we might spend a lot of time with inappropriate solutions, given that the problem really rests in understanding the relationship of these domains to people's health and well-being. So we can go on to the next slide. And I just want to, again, you don't have a lot of time, but I want to show you why it's important to understand some of the other factors that really influence, particularly what happened with COVID, but you could do this with any health issue. So overcrowding, when people need to isolate and quarantine, when there's transmission, when people are closer together, indoors in poorly ventilated areas, overcrowding becomes a marker for how easy it is for there to have unchecked transmission. And here the purple colors and even the sort of shaded blue colors, but particularly purple. The purple color here that you're seeing on the map, these represent the communities where we saw high rates of overcrowded housing as well as high rates of cases. And if you remember back to our earlier maps where we were looking at sort of just cases, hospitalizations, and deaths, I mean, same pattern. But now if you sort of look at what's the relationship between overcrowded housing and COVID rates, you see a correlation here as well, which is why I want to sort of ask us all to pay attention to some of the other things that go on in our communities that we know for COVID, it's easy to call them out. Next slide. Similar sort of color shading here, but this is related to food insecurity. So areas where there's high food insecurity and high cases, shaded in purple, with obviously blue being areas of concern as well, where we saw a lot of sort of high case rates and high food insecurity, along with relatively higher case rates. So again, relationships matter, and addressing these bigger issues is clearly going to be important as we're looking for solutions to close the gaps. And one last map that we pulled together, if we go to the next slide, it's a little bit of a different take on it, but it also, it acknowledges sort of, access to what in the case of COVID became sort of life-saving ability to connect, which was, did you have internet access? The darker shades here are households with very little internet or no internet access. And obviously the lighter shades of yellow were associated with, and blue were associated with higher internet access and higher incomes. So again, communities that have higher case rates have less ability to access the internet. Those are also lower income communities. And, not having access to the internet during the pandemic was a game changer. Hard to go to school, hard to stay connected at work, telework, impossible even if you had a telework assignment, and hard to do telehealth. So many of our healthcare facilities only were offering for a whole host of services, telehealth opportunities. So again, I'm just hopeful that this helps everyone make the connections between the conditions in which we live, have a huge impact on our health, and had a huge impact on people's health and well-being during the pandemic. Next slide. So it brings us to, what is the strategy for closing the gaps? Because we don't just have a long-term problem here, we have a short-term problem. We don't want to continue, since the pandemic is far from over, we don't want to continue seeing, again, with another surge, the gaps widening again. So how is it possible for us to think differently? And we started thinking differently, I'll be honest, last year. Like, this isn't new thinking. We just need to always keep it front and center. Urgently, we need to protect the most vulnerable. And that includes not just the groups we usually think about here, people who have serious underlying health conditions, people who live in long-term care facilities, particularly skilled nursing facilities, people who are vulnerable because they are experiencing homelessness and have no shelter, people who are incarcerated in very crowded situations. That's how we think about the most vulnerable, but we needed to add to that group one of the most essential vulnerable populations, which are essential workers, workers who never, ever got to stay home. And there's millions of them. So one thing is to protect those that we know are most vulnerable to COVID. The second is we do need in the short term to make sure that there are no gaps in access to the services and support that help us all live through a pandemic. And that includes sort of the most obvious, accessing testing, accessing vaccinations, accessing medical care, but it also includes accessing a place to stay if you need to quarantine or isolate and you don't have a place. That includes having some economic security if you're going to miss work because you have to isolate or quarantine, or you're caring for people who are sick. That includes addressing the fact that lots of people lost access to meal programs, and we needed to address huge increases in food insecurity. So that is part of the job to closing the gaps, because super hard to limit transmission if people can't isolate and quarantine, if they can't take time off to get tested or to get vaccinated. So we have to pay attention to the access issues. And then we have to be able to provide accurate information in a way that's transparent, that's respectful, and that's culturally aligned with people's experiences. So I'm going to give some examples of just things that we have done. I'm going to run through these also pretty quickly, but I think it's really important that we do things immediately when you start identifying these untenable, unconscionable gaps in outcomes. So we'll go on to the next slide. I'd say one of the areas where we focused a lot and continue to focus is on supporting workers. We've used health officer order authorities to create safety at workplaces, whole hosts of requirements. We continue some of those today, including, the very unpopular indoor masking order. But we also, have in the past required capacity limits. We've required certain impermeable partitions, spacing between workers. We've set up public health councils for non-unionized workers so that they have a voice and an ability to influence what's going on in their workplaces. We have hundreds of people on outbreak management teams. So as soon as there are 3 or more cases, we require a worksite to report to us. And our team actually goes out and investigates to try to make sure that we limit transmission at workplaces. We provide technical assistance and safety guidance to employees and employers so that they can work together to create that level of safety. We have a call center. We have specific lines for unions to actually get hold of us quickly. But we have a call center where people can anonymously report complaints so that folks who are feeling threatened at their workplaces because conditions aren't safe don't feel like they have to choose between losing their job because they're reporting to us and having somebody come out and help ensure more safety. And we take vaccines to work sites. So any work site that wants us to come, employees can request that we come, or employers, so that again, we're attending to the needs of essential workers. So that's farm workers, factory workers, manufacturing workers, grocery clerks, healthcare workers. These are folks who have been hardest hit throughout the course of the pandemic. And we have to make sure that we continue to protect them. I would venture to say that those surges that you see that disproportionately affect Latinx and Brown people really reflect the fact that disproportionately Black and Brown workers are in these essential jobs, do not have opportunities to do a lot of teleworking. And without protections at the work sites, there's higher rates of infection that then they take back to their families and their communities. And we end up in that merry-go-round that I think was so aptly described by Stephen at the beginning of the presentation today. Next slide. One thing else I talked about is there cannot be any gaps in the services. They have to be easy, they have to be available, they have to be everywhere. This is, has been sort of always a work in progress about reducing barriers. Right now, we did this first with testing, now we're doing it with vaccinations. But I'm proud to say LA County has 1,300 permanent sites where people can go get vaccinated. The network is vast. It is in every neighborhood. We supplement those permanent sites with 400 mobile teams every week that go to places where people are at, making it as easy as possible. Parks, metro stations, grocery stores, special events. We go to people's homes to vaccinate if they can't get out. And we've removed barriers. If you don't have transportation, we offer free transportation. You don't need an appointment, you don't need insurance, you don't need government IDs here in the county to get vaccinated. And this work continues to be important I spend some time going door knocking with my teams. I'll talk about that in a second. And I'm always struck by, no matter what community we're in, there are still people who think they need insurance, or they have to pay for the vaccines, or they're not eligible because they're not citizens. So we always have to work on making sure there are no barriers to access. In this case, I focused on vaccines, but it's the same work for testing, for access to medical services. Obviously, once people are sick, they need easy access to treatment as well. Next slide. So I just, this does make a difference. Here's where we started in May. The darker colors obviously represent higher rates of penetration. And as you can see, pretty much for most of the county at this point, we've got people in our communities that are vaccinated at close to 60% of folks having at least one dose, which from where we were at the beginning of the summer, there's been a lot of work here, but doing obviously much better. Next slide. But still, you can see gaps, places to go. Same thing, done a lot of work by school districts. This map looks really much better as well. Next slide. And I want to get to sort of a third example, which is, really needing to build these partnerships so that there are trusted messengers, and investing in this. It's really clear to us, like I would say the biggest eye opener for our health department was how little we're trusted. And that's due to a long-term legacy of not being trustworthy, and very little effort, I think, in the most recent times, to acknowledge that we needed to do a lot more work to build back that trust. When people are more inclined to believe a video on YouTube that shows a chip being injected into them when they get vaccinated than they are to, our teams and teams of other healthcare providers explaining that that's not possible, you have a credibility gap, and you really need to work on it. But the fastest way for us to work on it was to invest in other organizations that are trusted. And we did that in two ways. One is we funded a whole bunch of community organizations that could build a network of community health workers and promotoras. We worked really closely with about 350 faith-based organizations, again, have mini grant programs, but make it easy for them to set up vaccination clinics and for them to be able to speak to their parishioners. I'm really proud of the efforts on peer-to-peer messaging. So we created a community ambassador program, a parent ambassador program, a student ambassador program, arming other people with the kind of information that makes it possible for them to talk to others, their friends, their family members, and have information that can be shared. And then, of course, building out our partnerships with the healthcare providers that are trusted, federally qualified health centers, independent pharmacies, community clinics, and our schools and our school districts. So this has, been, I think, one of the more powerful partnerships that we've developed over time. I don't think we're going anywhere. I don't think we're going back in time. I think we really recognize how important it is to invest in community infrastructure, and that includes all of these organizations, not just for COVID mitigation, but just for strengthening communities in general. And I'm going to close just by acknowledging that I've talked these last three examples, and you can go to the next slide, about what we're doing right now to try to close gaps. But the real work is to do some policy and practice changes that will have long-standing impact, so that the next time we're here, this isn't the certain disproportionality in folks' outcomes. But to change that, we've got to change some policies and some practices. The first is we have to tackle the root cause, which is racism and discrimination. And we have to do that in a sensible way that actually dismantles policies and practices that contribute to the perpetuation of inequities and inequalities in how we distribute our resources based on some hierarchy that assigns value to the color of people's skin. So that's possible. That system is not a biologically based system, and therefore, dismantling it makes sense. But it's something we're going to have to work super hard at. We do have to address the long-term issues around housing, job, and food insecurity, the widening inequality gaps. Every place we looked, being poor made a difference in this pandemic. It makes a difference in people's overall health status. And we have to have better solutions, living wages, guaranteed housing for people. And we have to figure out a way in the richest country in the world that people aren't going hungry. Between production and distribution, we've got to get that better attended to. Some easier fixes. I don't know why we don't have paid leave yet. I don't know why California, we're as close to having universal health insurance, but we're not there. That stood in the way. I can't tell you how many people I talked to that cannot quarantine, because when they quarantine and stay out of work for 10 days, there is no paycheck. There is no food. There's no rent money. That's absurd. Nobody should be choosing between being able to get paid and staying home when they're sick, particularly during a pandemic. And that hurt us everywhere. Obviously, improving worker safety. I went into, and so did our team, into factories and manufacturing plants where the conditions under which workers work was dismal. Again, richest country in the world, no excuse. Huge profits being made by some of the companies we visited on the backs of poor working conditions that, again, of course, during a pandemic play a huge role in increasing transmission. Folks in the middle of a pandemic, where they were told to actually, make sure that people were spaced at least 6 feet apart, or they had impermeable partitions. In some of our clothing manufacturing plants, what they did, the administrators there did, is they took cardboard, cut out holes in the cardboard so that there would be no interruption in the flow of the piecework, and then said that was the protection for the workers. One of those sites, over 20 people died. So there's a cost to this and there's a price to this, and it's not able to be calculated. But this is now, here in LA County. This isn't something that happened in some other country or some other part of the world. This is right in front of us. And so we need to strengthen worker protections, and worker organizations need to both have funding and be able to have the right to organize and meet with workers. Because wherever there was a union, workers had a lot more protection. I'm not trying to sort of create some divisiveness here, but where workers were represented, there was concerted efforts to improve the conditions under which those workers were working. And where that wasn't happening, conditions were at their worst. And I don't also want to paint a picture that all of our businesses were like this, because they weren't. The vast majority of businesses are doing right by workers and customers. But where there are gaps, they're untenable, and they need to be addressed with longer term protections for workers. And obviously, I believe strongly that we have to understand that we need financial investments in community infrastructure. These are the economic drivers, as well as the trusted organizations that really are always called upon whenever there's an emergency. So whether it's COVID or it's a climate change disaster that we face in the future, we need our communities to be strong. And the best way to make sure they're strong is to invest in community organizations, into the built environment, into economic development opportunities in our communities. With that, I want to thank you again for the invitation. I'm happy to take your questions.
Thank you so much. So let's start with the questions that were emailed, and I'll just read them off. Now that masks are a part of the safe population's required safety gear, and for how long?
Yeah, so, masks are super important when you have a lot of transmission, and we have a lot of transmission still. If we were back in that color-coded system we all got used to at the beginning of the pandemic, we'd be in red. Like in red, almost everything was closed still. The only reason we can tolerate being fully reopened is because we have vaccinations and masking. So we're going to stay with masking until those numbers drop a lot. We've put out criteria for when masking indoors can we can consider lifting it. It requires 5 conditions. We have to see our case rates be in what's called the moderate tier by CDC. That means we're seeing less than 50 new cases a week per 100,000 residents. That's about 750 cases a day. We're nowhere near that. But once we get there and we're there for 3 weeks, that's criteria number 1. Criteria number 2 is we need to have stable and low hospitalization rates. We can't threaten our hospital system, and that benchmark is at or below 600 hospitalizations a day. We're pretty close to that. We need to have 80% of LA County residents 12 and older fully vaccinated. We're close to that. We're at about 73% fully vaccinated, 81% with 1 dose. So closer to that than we are to getting case numbers down right now. We need to have no emerging threats of a variant of concern that starts circulating widely that evades the vaccine protection. So this is, we pay attention to variants. If we were to get a variant for which the vaccines don't offer us a strong level of protection, we would want to keep our masks on because that would be what was left to protect us. So you wouldn't want to have your mask off if there was a variant circulating and the vaccines weren't giving us enough protection. For indoor sites, they're also for the mask to come off. Everybody needs to be fully vaccinated indoors. Now, for many of you, LA City just introduced a fairly massive requirement on vaccination verification indoors. So many places already are requiring that people be fully vaccinated. So I don't really think that's a big hurdle. I think the biggest hurdle is getting transmission down to a low enough rate that we can feel secure about not needing our masks. One of the reasons why we need our masks, like people ask me this all the time, if I'm vaccinated, don't I have a lot of protection? You do have a lot of protection. I showed you all the data, but you don't have perfect protection, far from it. So a couple of things on this. One is everybody needs to get a booster if it's their time to get a booster. So if it's 6 months out from Pfizer or Moderna, 2 months out from Johnson & Johnson, please go get your boosters. There is waning efficacy. We see it in our numbers all the time. Still a lot of protection, but not as much as we had at the beginning when we got vaccinated. And it would be helpful as we go into the winter to boost your own systems so that you get back to a high level of effectiveness from the vaccines. But because they're not perfect, when you have a lot of transmission, unfortunately fueled by unvaccinated people, but vaccinated people also will have higher rates of transmission as well, because it's not perfect. So if you go into a room and 20 people in the room are infected, there's going to be a fair amount of transmission. It'll mostly happen among people who are unvaccinated, but with that many people in a room that has 100 people, you're going to have transmission, and it's likely to involve people fully vaccinated. If you were in that same room and there was only 1 or 2 people that were infected, then the vaccinated people will be much less likely to get infected in that situation. So those numbers matter about how much transmission is going on in our communities. But I hope that answered it.
Yeah. So the next question is kind of a twofold. With the variants constant mutations, what is the accurate information as to how frequently boosters will be needed? And will there be a yearly vaccine?
Yeah, we don't know at all because, we're studying in real time what's going on. I think, people will also look back and see what's the appropriate timing for the sequencing of doses, as well as for when we might need a booster. Obviously, we found out we needed this booster because everything is, thank God for all of our scientists, everything's being studied in real time and analyzed in real time. And it was pretty clear based on data from here and from other countries that we were seeing a reduced efficacy in the vaccines. And that's what led to the need for us to come in after 6 months and get those boosters for Pfizer and Moderna. Efficacy wanes quicker for Johnson & Johnson, and that was a single dose vaccine to start with. So, saw some movement there after 2 months. People need that booster dose or second dose there. I would anticipate that boosters will be needed again, but I don't know what the timing would be on that, just because I don't think COVID-19 is disappearing entirely. I think we learn to live with this, and part of learning to live with it will be either a yearly vaccine or some boosters, and that may end up with us finding out that with this third dose, this booster dose, you end up with a lot of protection that goes way past the next 6 months, but we'll have to just wait and see what the data tells us.
Okay, the next question is also twofold. What do you see for the next 6 to 12 months in LA? And do you foresee an end to the pandemic? I guess you kind of answered that. We'll just have to live with it. But how is LA doing the next 6 to 12 months?
I mean, I think there's a difference between living through a pandemic and, where there's just, just a lot of devastation and loss of life and livelihoods, and living with a virus, So I think we're out of the pandemic when we can actually figure out how we live with this virus without this virus wrecking us. And that's very hopeful. I think the signs for that are super hopeful. We have powerful vaccinations. We have therapeutics on the way. We have 2, treatments that I think should hopefully be with us by the new year. That means that when people do get infected, we're able to prevent catastrophic illness and death, and that's huge. We have, what I call huge advantages and advances in testing, making it pretty easy for people to actually access a test and find out their status within a few minutes of getting tested. And that's also going to be really helpful. So I think, with those tools in front of us, we do get to a different place. But the key right now is we need to get more people vaccinated.
Okay. 2 more submitted questions, and then we'll go to the chat. Why are gyms in LA County not required COVID vaccination statuses, whereas the city of LA, San Francisco, and West Hollywood do?
Yeah, thank you, city of LA, West Hollywood, San Francisco. We applaud, any city that moves forward with, a set of safety measures that are sensible, and obviously, in settings where there's higher risk, it does make sense, I think, to require that people are fully vaccinated. And these are settings where you don't have to go to these places. It's not the grocery store, it's not the pharmacy, it's not a healthcare facility or an essential service. And I think at this point, we have an obligation to each other to layer in that protection. One reason why the county moved somewhat differently is because we are the county and it's huge. This is a huge county with thousands and thousands of establishments, and our capacity to actually ensure compliance is limited when we don't have a lot of support from a lot of the cities. So it's easier to imagine a situation like we did. We took the highest risk settings, bars, nightclubs, lounges, and large mega outdoor events with more than 10,000 people where there was a lot of crowding going on, and made a requirement there for vaccination verifications. And then working closely with cities and other jurisdictions as they implement to support it. Because we can play a supporting role. It's just super hard. There's, I don't know, I think 30,000 restaurants across the county. It's, it requires at this point that we really are able to give good technical assistance and do a good job on inspections and compliance. And we need support and help to do that. It was really hard the past year as we tried to get high rates of compliance for, remember, capacity limits and all of the other rules. But we wanted to really make sure there was opportunity for us to have deeper partnerships with our sister cities on moving forward. So we are 100% working collaboratively with those cities that have moved in this direction, fully supportive of these efforts. But we do need that partnership to implement vaccine verifications more widely.
Last submitted question. Well, thank you for your leadership spearheading us through this pandemic. And as a public health professional, what has been your biggest challenge you faced during this pandemic in your job?
I mean, I think the disaster of disproportionality. I mean, I can't tell you how heartbreaking it is to watch this play out, really since April, right in front of our eyes, and to keep trying to close the gaps, but not really being all that successful. Like, that has been the hardest part of the work.
Okay, well, thank you. So we will move on to the chat questions. Do you have an estimated of natural immunity for adults in LA County, people who have been infected by some COVID-19 variant? On the last CDC clinician call, it said 38% of children in the US have been infected by a COVID-19 virus.
Yeah, I think it is such an important question. The evidence is pretty clear and becomes clearer, every week with more and more studies, including a couple of recent CDC sponsored studies, that natural immunity, it's there, it's real. It doesn't last that long. It's impossible to measure how effective it is. And it certainly looks at this point like it doesn't offer the same level of protection that vaccines do. So I think the big issue for all of us to understand is, even if you've been infected with COVID, it's really important to still get vaccinated. Okay.
For your slides on race, is that self-declared, or is there another way that they're tracking how people are declaring their ethnicity and race?
It's self-identified.
Self-identified, okay. Are there specific stats on the homeless population of incidents of infection, hospitalization, or death?
Yes, and you can go to our website and see the report on people experiencing homelessness.
Can you tell us your website again, and I'll put it in the chat?
Oh,
that's I think it's LA Public.
Yeah, I think. Oh, I don't know. I don't want to say it wrong. So let me try to get that in before we end. I'll get it for you.
I can do a quick Google search. Okay. Okay. So the next question is, let's see. How do you explain the reluctance of first responders to be vaccinated? It doesn't seem to be a race or poverty issue.
Yeah, so I think it's a great question and important for us to really understand why people are making a decision not to get vaccinated, and then being adamant in some cases, not just not getting vaccinated, not getting tested, and sort of not being part of this effort that we have to protect each other. I want to start by saying that, for the LA Police Department, 73% of their members, all of their employees, are fully vaccinated. I think what happens sometimes is there's the folks who are most upset by this are very loud and take a lot of airspace, and they articulate their unhappiness, and it makes it sound like most people are unhappy, but I don't think that's true. 73% of people fully vaccinated, and I think there's a significant number of folks partially vaccinated who will become fully vaccinated, means that, again, the vast majority of people working in those fields are in fact getting vaccinated. And for those people who are adamant about not getting vaccinated, I think these mandates are not mandates that say you have to get vaccinated, and we should keep that front and center. These are mandates that say, in order to do this job, in order to come into this place, in order to engage with other people, you have to be vaccinated. So healthcare workers, first responders, people who are in direct contact with the most vulnerable among us need to not create additional risk. And I hear that there's other ways to mitigate the risk, but the most powerful way to prevent transmission is to get vaccinated. And just like, we are not allowed to smoke when we're nearby other people, because our smoking, while it seems like so personal, actually affects the health and well-being of everyone around us. People need to get vaccinated if they're going to do certain jobs or they want to go into certain settings. So you do have a choice. Everyone has a choice about whether they want to get vaccinated or not. But as you make that choice, there are consequences, just like there are to everything. When we get in a car, we follow the traffic rules. We put on our seatbelts. When you come and work in a healthcare facility, you have all kinds of requirements about which vaccines you need to have. If your child goes to public school, they need to be vaccinated. Many employees require drug testing. So there's all kinds of things we do about how we take care of our own bodies and our relationships with others that are in fact governed by a set of rules. And this is one additional set of rules in the middle of the worst pandemic any of us has ever seen. 27,000 people will have died by the end of the year here in LA County alone. And close to 1 million people will have died across this country. So there is nothing but tragedy in these numbers, which represent individual lives that are gone and individual families that live with that loss forever. So I get that people like having choices, but in the pandemic, the number one choice we all have to make is to take care of each other. And if we can't do that, then we need to not do some activities that create a lot of risk. So I feel strongly about this, as you can tell. I'll give you our website. It's www.publichealth.lacounty.gov. Sorry.
Thank you. No, it's fine. I found
different websites going.
I found all your social media channels and I put them all in the chat from Twitter, Facebook, Instagram, and YouTube. So if you're looking for any public health social media handle, it's in the chat. Last question before we open it up to general questions. How can we ever hope for herd immunity when so much of the world is still unvaccinated?
Yeah, be really hard. I mean, herd community, the way we think about it is a rate of protection that you have in the communities you're living in. And because you have a high enough rate, like with measles, you don't have a lot of transmission even when a case is introduced, because there's just not a lot of places for the virus to go. But you're absolutely right to note that until we deal with the issues globally of access to vaccines, everybody wherever they live should have the same access we do. Until we get that access so that everyone can get vaccinated, there's a lot of risk at always reintroducing the virus. And unfortunately, because it is a virus, reintroducing dangerous mutations of the virus. So we create risk. We can get to community immunity like for LA County, but to stay fully protected, we do need to deal with the situation across the world.
So we're better off just staying in our LA bubble and not in California.
We're better off advocating for a better system to distribute vaccines, right? I mean, if really, I could talk a lot about, the rules about, who gets to make vaccines and, really, why people, in Central America and Africa don't have the same access. And it's not because they don't want the vaccine, so.
Okay, well, thank you, everyone. I'm going to open it up. So if you have a question, you have the option to unmute yourself. Please raise your hand and I can call on you, but you now are able to unmute yourself and ask a question. So let's go ahead and begin. Any questions?
I have a question.
Sure, Margaret?
Yes, Dr. Ferrer, how accurate do you think the in-home kits are for,
the testing kit?
It would just be interesting. Yeah.
Yeah, no, as long as you get an FDA approved testing kit, it's pretty accurate. So, go ahead, just make sure it's FDA approved. Lots of charlatans trying to sell products that, really haven't been tested, haven't been approved. So go with an FDA approved home test kit. There's, I think, at least 3 on the market right now, and you'll be fine. And they are accurate enough. Again, we tell folks, if you get a positive test on an antigen test, you should go ahead and get a confirmatory PCR test.
Okay, thank you.
All right, next question. I have 3 different screens to slide through. So let me see. Any other questions? Claudia, go ahead.
I'm still muted now. I just want to thank Dr. Ferrer. I worked at UCLA's micro lab for 37 years. And it just is very upsetting to me that even some of my former colleagues are skeptical of some of this. And it's just whatever information you can continue to present to us, please do. We really, really do appreciate it. So thank you so much.
Thank you very much for your kindness. Thanks a lot.
Okay, this is like a once in a lifetime opportunity. So if you have questions, please feel free to ask them.
Yeah, and Aisha, I probably have to go in like a couple of minutes.
Sure, okay. Elizabeth, do you have a question?
You alluded to 2 promising treatments that we might be having soon, and I wondered what they were. And I also want to say thank you so much for being here. You are an inspiration. Thank you.
Thank you guys. We've all been in this together. So both Merck and Pfizer have medications that have been, hugely successful in their clinical trials. I know for sure Pfizer submitted to the FDA, and I believe Merck did also. So it's really at this point a review. Pfizer's is an antiviral. I know a little bit more about Pfizer. They actually ended the clinical trial early because it was so successful at preventing the advancement to serious illness. I don't think anybody in the clinical trial who was given the medication passed away at all. They were very, very positive results. So we're anxious, obviously everything needs to be thoroughly reviewed by the FDA. And we don't want any corners cut, but it was really, really promising, and we're glad they've submitted, and we're very hopeful. We've always said all along, there are 3 things that we need to be able to end the pandemic. We need great vaccines, we need really easy and cheap, inexpensive testing, and we need medications, treatment that can directly reduce the burden of serious illness and death.
So let's take maybe 1 or 2 more questions. Michael, did I see Susan Abels? Was your hand up, Sue? No? Okay, so Michael, and then if anyone has 1 more question, we'll let Dr. Ferrer go.
Thank you again, Dr. Ferrer, for joining us today. All this great information. Is there a big concern about a confluence between the flu season and COVID-19?
Yeah, thank you. It's great. I get to plug flu. So please get your flu vaccines, your boosters and your flu vaccine. Yes, there is. And that's why we need to be particularly mindful of keeping our healthcare system intact. Last year we didn't have flu really to speak of. We had a handful of cases here in LA County, but also across the United States. Most people were home and everybody's wearing masks, and kids were not in school, and kids are a big driver of flu. So kids are back, everybody's back at work for the most part, or many people are back at work, and we're doing a lot of intermingling. So if we're not careful, that could lead to a very, a difficult flu season. And we already had our first death from flu. So just so everyone knows, we're already in flu season, but it's not too late to get vaccinated. And yes, at all of our vaccination sites where people can get vaccinated for COVID, we also offer flu because we do want people to get both, and you can get both at the same time. That's the good news. 1 in each arm is perfectly fine. No reason not to. And then you're done and ready for the winter. So yeah, thank you for raising that. If you had 600 to 800 people hospitalized each day for flu, on top of 600 to 800 people hospitalized for COVID, you would create a stress on the healthcare system. So we do want to avoid a very bad flu season.
We have time for maybe 1 more question. If not, we will conclude. I don't see any hands. Okay, well, Dr. Ferrer,
Thank
it's
you.
been a pleasure. I thank you so much for making time for our group. And, we at UCLA pride ourselves on being kind of at the forefront of vaccines and boosters. So I do encourage everyone here, if you haven't gotten your booster or your flu vaccine, check the UCLA portal to schedule yours as soon as possible. And I will be submitting the video to our YouTube channel so you can check it out later and share it with your friends and family. So any other final words, Stephen, Michael? Okay, well, thank you so much.
Everyone.
All right,
Thank you.
Everyone keep safe.
that was fantastic.
Thank
Yeah.
you.
Thank you.
Okay,
Thank you
well,
so
I'll let you have your afternoon back. All right, bye, everyone.
Bye-bye.
Bye, guys.